Rupert, thank you for having me, and thank you for all of you who are attending. I see on my end one of my co-authors of the paper, Julane Andries, is on. Not sure if anyone else is. So, a brief introduction. I go all the way back. In my youth, I was very involved with the legal period of MDMA and as a psychotherapist in that, psychiatrist. We had the luxury of working legally with hundreds and hundreds of people. And I think a lot of what we know about psychedelic medicine came out of the legal period. And then we were shut down, and, MAPS came out of that. And so did our general interest in the furthering of psychedelic psychotherapy as basically a revolution in the consciousness of humans and in the work that we do as psychotherapists, because it changed the whole deal from the 45 or 50-minute hour to the really being with people, understanding people, being more exposed, having different ethical dilemmas. The whole process of the work changed, and it put psychiatry, psychotherapy into a new dimension, a dimension of seeking people's wellness, healing, happiness, and left really, and we're still leaving it, the suppressive aspect of psychiatry behind for the liberating aspect, which is really what this is all about and why I've been interested, because the game is love, sharing, and connection, and psychedelic psychotherapy offers the possibility for enhancing that for many human beings that wish for more. The more we train people in it, the more we have the option of developing that. And I am very involved in what's called Ketamine Research Foundation. I hope you'll take a look. We're doing a variety of research and establishing ourselves as a freestanding research organization, as well as training. We've trained over 600 practitioners in CAP, ketamine-assisted psychotherapy, and it's ongoing, and we're getting a little more international. And we have an organization that we're building, which is called the Ketamine Psychotherapy Associates, which I hope at some point, as MDMA, psilocybin become legal, other substances, that will change it to the Psychedelic Psychotherapy Associates, and keep training and developing our concepts and our methodologies, our approaches to humans, and our sharing between each other. So conceive of this morning as a sharing. Why did we undertake this study of lactation? There are two basic motivators. The first one is essentially about ketamine itself. We view ketamine as a first-line antidepressant. In our practice, which is multitudinous, we have wonderful results, not usually with one session, more or less like IV experiences. We have multiple sessions. We do them in office, at home, under close supervision, and we use two major modalities, and those are the sublingual lozenge, which is not abusable, and we use intramuscular injections, and we do this all in office. The study we're going to talk about was done in office. So basically what occurred is that, as we understood ketamine to be a first-line antidepressant, we also saw other characteristics that made it very desirable for potentially postpartum depression and women who are lactating who might be depressed or struggling with trauma. And those characteristics are straightforward. That is, ketamine is an intermittent use substance. We can use it without going every minute of every day and exposing infants and women to it continually. So we have its intermittency. We have its short half-life, so that 2.1, 2.2 hours, and the norketamine half-life of 1.2 hours as its principal metabolite enables us to really work with it on an episodic basis. The second part of that relates, and the second part is what I've been calling the mother's dilemma. So women who are depressed or having postpartum depression are faced with choices, and the choices are not always pleasant in their minds or our minds if we're thoughtful practitioners, and that those choices are a continual exposure of the infant to an antidepressant such as fluoxetine or others. Um, and the unknown, because they remain unknown, doing prospective studies is very difficult on child development. The unknown affects long term if a woman is secreting in breast milk significant quantities of an antidepressant or other medication, a benzo, etc., commonly used for treatment of postpartum. The other part of that is the inefficiency of conservative care for postpartum and the prolongation of treatment. And in our view, ketamine offered, and we have to go ahead and do the study, of course, offered the possibility and offers the possibility for more rapid resolution of postpartum depression when situated in a context of family-centered care. And that's what we'll be moving towards. So those were the motivations. Do we have significant amounts of ketamine secreted in breast milk, and for what period of time? So let me take you to the screen share, and I'll take you through the study. Give me a second to bring it up. I've got to get this to the slideshow. There we are. Okay, pharmacokinetics of ketamine in breast milk of lactating women. We had a great deal of help from Jason Wallach, who's a wonderful neuroscientist, and we had analysis being performed at the UCSF lab, and it's a straightforward study, and it's a small number, but as you'll see, the significance of the small number is of such power that we didn't have to do longer. So we're looking for what's a safe time frame for ingestion of breast milk in nursing infants when ketamine is potentially used for the treatment of postpartum emotional disorders, or for women who are depressed but still breastfeeding. Many women are breastfeeding for long periods of time, a year, 2 years, 3 years is not uncommon. So these are already the results. So what you see is on the for the ketamine, which remains the principal active substance involved. And remember, we're not doing first pass. We're doing in this study 0.5 milligrams per kilogram IM, and a second round a week later, 1 milligram per kilogram IM. We selected those dosages as being basically indicative of practice that, often people will exceed 1 milligram per kilogram in an injection, but generally it covers the terrain and it gives us nice curves, as you see. And we did full pumping of breast milk at intervals of 3 hours. And if you look, the red line is the high dose. As you would expect, there are more nanograms per ml from the high dose, but the curves come down quickly in accord with the what we know about the rapidity of the metabolism of ketamine. So you can see at the 3 hour mark, which represents 3 hours of ketamine and metabolites, norketamine, the active metabolite, which is about a quarter the strength of ketamine and is much more present in first pass oral ingestion. And then the two inert representative metabolites, hydroxynorketamine and dihydronorketamine, both of which are inert and don't play a role in this. So the two main actives in this are ketamine, of course, and norketamine. So you can see that in the 3 hour point, which is a full collection of 0 to 3 hours of ketamine and norketamine, you have the high point, and they're proportional to the dosage. And the range reflects weight. So one of the main issues in our ketamine world is, do we do dosage by weight, or do milligrams per kilogram, or we do dosage by sensitivity with reflection on milligrams per kilogram? Our practice is, of course, the latter, that we are looking for people's sensitivity. We're starting people off at low dosage. We're trying to assess how much depth they achieve given dosages. We usually start with sublingual ketamine, but we may start with low dose intramuscular ketamine. And what you see is that by 6 hours, in proportion to the metabolism, the amounts of ketamine have fallen off, as has norketamine. It persists, norketamine, a little longer, but the amounts are lower. It probably persists a little longer because it takes time for metabolism to occur. And by 9 and 12 hours, you can see you're pretty much flatlined on both of them. So what that showed to us is that ketamine is present in insignificant quantities. Remember, these are nanograms in breast milk. Micrograms after 6 hours, a few micrograms, but nanograms in women of different weight. And we had 4 different ethnicities, even though there were only 4 subjects. And the curves were so overlapping that we didn't feel we needed to pursue more patients. We did a real-time analysis of the first woman that we worked with. So we, and see if I have the slide for you. We took her out to 36 hours, and I may, after I finish this, bring that slide up. So trivial amounts, nanograms, and if you look at fluoxetine curves, they represent about 10% in occurring in breast milk and neonates. That's quite a bit of fluoxetine. The main studies have been on sertraline, and you can look at those and see that while there's small amounts, in essence, their continual exposure means that infants are subject to that over the course of their mother's use of the medicine. And with ketamine, of course, the point is that it's intermittent, and you can structure the therapy according to symptoms rather than according to daily use of a medication. So the study population was 4 women breastfeeding for at least 3 months' time, 50 kilograms or greater. And of course, the curves, the range in the curves represent weight, so that if you do milligrams per kilograms, obviously the heavier the person, the more they get, which means the more they have of a ketamine experience as well, which is one of the difficulties, I think, in studies around ketamine. So if you have a 50 kilogram person and you're doing 0.5 milligrams per kilogram IM, that's 25 milligrams. If you have a 100 milligram, 100 kilogram person, then you're going to have 50 milligrams, and the effects are going to be quite different. So our interest is in the subjective experiences of people and in their healing aspects as a result of that. These were random, selected by referral. Breast milk was collected fully at 3-hour intervals, quantified and sent to UCSF. I don't know if I can move it so you can see under the gallery. The end result, I can't do the right side. The outcome is hard to see for you, at least for me. The suggestion is that ketamine is safe in breastfeeding at an interval that a woman can choose based on the data. We didn't make an actual recommendation because of liability issues, and we felt also that the data spoke for itself, and that's how we presented it. But as you looked at those curves, you can see that really after 6 hours, if you pumped for 6 hours you certainly would have very small amounts. In fact, very small amounts are secreted in breast milk in general. So this is the data. It's very hard to see. I can't really enlarge it, but it's per person. And let me see if I can bring up some other charts. I'm going to let go of this screen and try a different share. Sorry. Okay, there it was. Let me go back. So I think this is the one I want to share. So if you look at compound across time, these are in nanograms, and breast milk concentrations in nanograms of ketamine metabolites for a single subject following 1 milligram per kilogram. This was our lead person, which made us, as you look at the data, enabled us to say, okay, well, here we are at 12, 24, there's really next to nothing. It's within more than acceptable limits. So that we then constricted the time frame to 12 hours of follow for each of the people that we had in it, in the study, each of the 4. And this is the total amount of ketamine secreted over that period of time. So we had a full view of that, and here's the curve. You can see that at it's pretty trivial even at 6 hours in terms of nanograms per kilogram, and it basically goes asymptomatic on it. Okay, let's see if there's one more to show. Let me get out of this. I don't think you'll be able to see this very well. That's pretty much the same. So this is a full data sheet. It's going to be very difficult for you to view, but you'll see the 2 dosages per person across the top. Let's get there. So again, I can't really enlarge it on the screen to help your eyes or my eyes, but it substantiates the same results. So we can always go back to that, but that's really the data. The data is really encouraging. We're moving into a phase of developing our protocol for a major postpartum multi-site study, which again will be contextualized into family treatment, because we want to, when we do studies, we want to present ideal situations that are models for the practice, in this case of treatment of postpartum depression. Hopefully we'll get that going through the Ketamine Research Foundation by winter. It all depends on how strung out I am on work and my colleagues. So thank you very much. I'm open to questions and any interest that you might have in all of this.
Brilliant. Thank you very much indeed, Phil. That's really clear and interesting. Thank you. I just have a few questions about the study, if that's all right. Sure. When you're saying that the amounts are trivial, and I thought that last graph where you could see the asymptotic approach, particularly at 24 hours. And I know that you want to avoid making statements about how long people should avoid ketamine for breastfeeding after ketamine because of the liability issues, but that doesn't apply to this forum. And it just looked to me as if you know, if you wanted to be really sure that it was all out, then 24 hours looked pretty good from that time point. But you know, that's a conservative view, isn't it?
Oh, let me put it up again, Rupert, because
yeah.
I think that is a conservative point of view, because I don't think I think the graph shows something else. So let me take that on.
That one, yeah.
So if you look,
12 hours, I suppose.
really, it's trivial after 12. I mean, the
Yeah.
difference is
Yeah.
you're in tiny amounts of nanograms. They're basically because of the lab's capacity for sensitivity to look at that, but you're not. If you were to take 12 hours as a safety margin, I think you're certainly within the framework. The problem of longer postponements is that it interferes with the relationship between mother and child. One of the
Sure.
aspects of this was to uh, be able to keep that relationship going without significant postponement of time with safety. And I think if you really look at 9 hours, you're under 50, or you're at about 20 micrograms, nanograms rather so it's really trivial amounts.
Phil, I'm
And
sure you'll
so
have it in the.
if you withheld here or here, you're going to have virtually no absorption. When you resume, you're resuming in this period.
Yeah.
So
Okay.
this is an election at 12 hours.
I'm sure
So
it's going to be in the paper, but can you remember what the sensitivity of the lab analysis was? You know what? I mean,
well, it's in the paper, but it was really, really high. You,
no, don't worry, don't worry. We can look it up. We can look it up. I'm just wondering, just how that
well,
compares.
it was really extraordinarily
Yeah.
sensitive.
Okay.